Another question, Doctora. Is the FOUR score, the FOUR score, more accurate than GCS as a tool for NBS for deep coma or vegetative patients?
Yes.
Is it more accurate than GCS though, the fourth?
Yes. So the FOUR score, or the full outline of unresponsiveness score, is actually just to give you a background, the Glasgow Coma Scale kasi has been given for has been used for a really long time. It was initially used for patients that were on the field, so mga war patients, trauma patients, no, so that you could have rapid communication between one emergency provider to another. But then na-translate na siya to something that we use on an everyday basis when we try to communicate the neurological status of a patient. But if your patient is intubated, automatic hindi mo na ma-evaluate yung verbal output in the GCS score. So you have eye movements, you have verbal, and you have motor. So natatanggal yung verbal. But the full outline of unresponsiveness score actually does not need the verbal output anymore. So it can be used for patients that are intubated. And it can be used for somebody who cannot communicate, like for example, hindi makapagsalita. So it also takes several brainstem, and your pupillary responses are also there. So kaya technically, no, if you want to be able to communicate better in an ICU setting or even in a hospital setting, the FOUR score is actually a more useful tool for me. Kasi maraming nuances na yung GCS. It's just an easier score to do. But the FOUR score for me, as a neurointensivist, it gives you more information. And it hindi mo na problemahin yung naka-intubate yung pasyente kaya VT na siya o kaya V1. So it's more accurate.
Okay, thank you. Another question, Doctora, before we return to Dr. Calderon. Doc, in cases of coma, how long would you recommend the family to wait or hope for the patient to show signs of life or consciousness? If after a few years, grabe, no, of waiting, and when they decide to stop treatment, who usually pulls out the contractions? Is it the AMD or the family?
Okay. So there are two nuances to this question, and I think Dr. Calderon would like to answer the second part of it.
Oh, yun nga eh. Pwede nyo sagutin
yeah.
eh.
But I'll answer the first part. So, and I'll give my opinion about the second part too. So the first part of your question was, how long do I wait? So if your patient...
How long would you recommend the family to wait?
Yeah, if the family... Okay. So if the minimum waiting requirement is 24 hours. How long you want to wait after that is really up to how much... if you're not able to determine brain death. This is a question about coma kasi. This is not necessarily about somebody who's brain dead. So the argument there is, kung comatose yung pasyente, persistent vegetative state, minimally interactive with the environment, nag-open lang ng eyes o kaya hindi gumigising pero may sariling paghinga, or siguro naka-ventilator siya na pero naiuwi ninyo kasi hindi niya kailangan ng vasopressor support. You can actually keep this patient on this support for years if you want to, because technically they're not brain dead. Kung meron silang eye-opening, kung meron silang pupillary responses, all the other prerequisites I previously mentioned to you that have to be fulfilled for brain death. So if they wish to sustain support for somebody who is in a minimally conscious state or a permanent vegetative state for as long as they can, then that is a decision of the family. But it needs to be clear that the patient's condition may no longer improve. And it also needs to be clear that there can only be a rocky deterioration kasi complications will eventually set in. And if this patient, however, after the first 24 hours na talagang ginawa mo na lahat, and you know that there is definitely devastating neurological injury like a massive CVD bleed na herniated na yung pasyente, at nagbigay ka na ng lahat ng pwede mo ibigay for 24 hours and you know that there is no way to go but down, then you can actually start talking about evaluating this patient for brain death if you fulfill the criteria of a patient being comatose with all the absent neurological findings. So that's the first part of it. Now about pulling out contraptions. I am not an advocate of asking the family to pull out contraptions kasi ikaw yung physician. You are the specialist. You know what those devices are for. Ikaw din yung naglagay. Ikaw din dapat ang magtanggal. The burden of the psychological, the emotional, and probably even the religious burden of having to pull out these devices cannot be put on a person who is not knowledgeable about what these devices are. But that is my opinion. I know that there's been years ago, even back in tertiary hospitals where I used to train at, before the advent of critical care coming in, it was tradition to actually have the family members pull out these devices, which I was completely not for. I think that it's our responsibility as healthcare providers to actually guide the family and support the family in this kind of decision. It's enough that they made the decision to forgo treatment and to say goodbye to a loved one. Huwag na natin dagdagan. But I will leave that part again too, because of course, Dr. Calderon will have a formal justification for that. Yung sa akin, medyo personal opinion lang.
Actually, Dr. Joanne already answered the question. No? But siguro, yeah, I agree with what you were, with your personal and professional opinion on this. First of all, there is no universal consensus on who should pull the plug. And then yun nga, there are many sides, or there are many versions of policies. No, na should be patient. It will be the patient's family or the relatives or the healthcare team. Not necessarily the doctor, but healthcare team. No, but then again, I personally and siguro ethically na rin, psychologically, I agree with you that the psychological burden, and all those psychosocial the psychosocial nuances, no, that we have that are clouding the emotionally charged environment, no, at this point. But then again, I think what we have to be clear about is the patient, whoever pulls the plug does not kill the patient. Kasi baka sabihin, ay, hindi na lang kami kasi ikaw yung pumatay. Ikaw yung ano. So, no, the patient died of the natural course of the disease. It's the expected outcome of pulling the plug. So, I think it has to be clear-cut. That's why in our hospital policy, although of course this policy is only applies to institutions, to respective institutions. Here it is the healthcare team, no? But it is witnessed by by relatives and their legal representatives. So I think na rin for the matter of legal protection of the healthcare team, as well as the hospital or the managed care institution, it has to be a witnessed event, or it has to be a witnessed how do you say that, medical procedure, so that when someone feels uncomfortable, no, kasi di ba anybody can file a case, no, any concerned citizen can file a case. So you have witnesses who will be by your side. So, but then again, that's defensive medicine. But of course, we cannot set aside defensive medicine. Ethics-wise, no problem. Whether it's the patient or whether it's the patient's family or the doctor, it's okay. But it's actually a matter of tradition and a matter of policy. So,
So we still have many questions, but I'm being informed that wala nang time. Maybe we can ask one more question. Dr. Calderon, hi Doc, what would you do if a patient asks you as part of her healthcare team to swear or to hide or not to disclose the truth of his or her condition to a family when asked?
Okay. Thank you for that question. Well, if that is my patient, then the patient does not want to, for me to, does not, well, in the first place, I am not supposed to disclose the diagnosis to anyone else other than my patient. Of course, that is very Western. Sa atin kasi, in our context, no, it depends on the disease or it depends on who is present. But ethically speaking, formally speaking, we are only bound by confidentiality with the patient only. But then now, merong mga stakeholders na, for example, you disclose a chronic disease, no, and the patient you think will require psychosocial support from the family, then we have to communicate with the patient. Why do you not want this to be disclosed? So I think communication is central here. We as the healthcare team members, we need to explore what are the insights or what are the reasons behind this request. Because it's also contentious. What if, for example, the patient has a communicable disease, so let's say an STD, and then you don't want sasabihin sa'yo ng pasyente, doc, please don't tell anyone. But then you know that the patient is sexually active with the spouse, with the legal spouse, with the husband or with the wife, whoever that is. Siyempre, meron siyang nagiging risk na siya dun sa asawa niya. So it's on a case-to-case basis then, no, when we have to convince patients that they need to break the confidence. But there are of course legal circumstances wherein we can break confidence, no. For example, when the doctor goes to court as a witness, or when the patient poses a public threat or a threat to someone else's life or liberty. So may mga exceptions po na ganun.
Okay. So thank you, Dr. Calderon and Dr. Robles, for the wonderful answers. And that is all the time we have for the Q&A. Sayang, ang daming tanong eh. Ang daming mga questions na okay sana, pero well, time constraints. Thank you very much.
Thank you.